Salam. Hi, how are you? My name is Yayi Suryo Prabandari, just call me Bu Yayi. I'm a lecturer at the Department of Health Behavior, Environmental and Social Medicine. So today, I would like to share with you about risk behavior and its prevention. In this session, I would like to give you understanding about health determinant, and then healthy and unhealthy behavior. I also will explain about how behavior is performed, and then I will end this session with a case of risk behavior, and I choose smoking behavior, tobacco as risk behavior, and then the burden of tobacco, and the role of doctor in tobacco control. So according to WHO, health is a state, complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And the health determinant is developed by Bloom. This is a classical theory that said if the health or health status is influenced by behavior, health services, genetic, and environment. So according to this theory, somebody will have a good health status if she or he apply a healthy behavior, and then fortunately, he has a parents that also healthy. This is based on the genetic factor, and he or she live in the good environment that makes him or her healthy living. And indeed, he or she live in the area that health services is available. But this health determinant is not only 4 factors, but also the WHO also developed what they call the fundamental condition and resources for health, such as peace, shelter, education, food, income, a stable ecosystem, sustainable resources, social justice, and equity. I will explain a little bit about this fundamental condition. Just if you have a good education or you have the high education, you will get a good job. After you have a good job, I'm sure you will get a good salary that makes you have a regular income. Within the irregular income, you can buy a good food, and I'm sure you will get to buy a shelter. And a shelter that with a good money, I mean that your house will be in a good location. So you will have a sustainable resources, I mean the water and the infrastructure in your house. Peace, yeah, and then you will also have the social justice because you are living in a good complex. Yeah. But this is will you get when you have a good money and good salary, and this is in this situation or in this era, you will get a good job if you have a good education. So all the condition in what they call the fundamental condition for the resources of health, so this is very important to have a good health. So if you see the condition on the health status of developed country, they usually give the education for their citizen. So they also give a good house, or they will give chance to the occupation for the citizen in this country. So there is a correlation between the high education and also the status of health in the country. And why the some factors is important to be discussed, because based on evidence, you will also learn and have practical session in this course, Block B5, about evidence-based medicine. This also a very good practical session, because you will learn and then you will get understanding about why some factors that related to health need to be learned and then need to be known by medical students, because disease is not only caused by very little substance or virus, for example, and then bacterial, but also can be because of the unhealthy environment, as well as in the last 5 decades, the research shows that healthy life, or what we call lifestyle, is also can influence our health condition. The WHO in 2008 is developed what they call WHO Commission on Social Determinant of Health. This is, they make expand of the fundamental condition for the health. So I already talked to you about some condition, and then the WHO add with some factors. Income and social status, we already discussed it. Education, and as well as physical environment. And then the commission is also discussed about the employment and working conditions. So to get the good living is not only we have occupation, but also our working condition should be good and healthy. For example, here in Indonesia, actually the Ministry of Education has already rules for the size of the lecturer rooms. For example, the lecturer should have one lecturer, one room, and then it's enough for working, because lecturer has to prepare to the lecture. So she or he has to have the what we call a good environment for working. So the employment and working condition is very important to make the people or the person work properly, and then in what we call the healthy condition. And then the other things that also important in these factors is social support network. So the support from the families, friends, and communities is linked to better health. If you live with your family, or maybe you live in the what we call a boarding house, but you have a good friend in your boarding house, so you will happy, yeah, you will happy, and then you will have a good relationship that also this influence your health. And WHO also mentioned about culture, custom and tradition, and the belief of family and community can also affect to your health. Why? For example, in Yogyakarta, the people like to eat very sweet. So we eat sweets every day. So this will cause that some diseases, for example, diabetics, can be influenced by this habit. And it is also shown in the national survey that diabetics in Yogyakarta is the highest in Indonesia. Yeah, because maybe this is also because of our culture. Everything should be used sugar. Yeah, we put sugar in the soup, we put sugar in our drink, and so this culture sometimes affect to your health. So another factor is the genetics. Inheritance plays a part in determining lifespan, healthiness, and the likelihood of developing certain illnesses. But we cannot avoid this genetic. This is just one factor that contribute to our health. The other factors that related to the behavior is personal behavior and coping skills. So we need a balanced eating. We need to keep active, doing exercise, and then avoid smoking, avoid the smoke of cigarette, and then enough drinking water, and how we deal with our life stresses and challenges to affect health. And as the Bloom said, that health services is also contribute to our health. So we need to access to the health services whenever we got illness. And then gender is also play roles in your health status. I mean that the men and women sometimes suffer from different types of disease at the different age. So from several factors that Bloom said, and then WHO also mentioned, and one of the big factors is behavior. So in this part, I will explain about health and unhealthy behavior. The WHO reported in 2011 that cause of death in 2000 and 2011. And then the cause of death is the highest is the ischemic heart diseases. And then next is stroke, and then COPD is number 4. And then the other non-communicable diseases. So the non-communicable diseases is already in the same rank with the communicable diseases, that both of them actually link it with the behavior. But more in the non-communicable diseases. And if we see the across countries, the pattern of communicable diseases is also similar, as well as in our country, Indonesia. So the cause of death across countries that shows Indonesia is including in the upper middle income countries. And in Indonesia, the non-communicable diseases like ischemic heart diseases, and then stroke, and then diabetic, and then the road injury is already in the high rank. If we see the Indonesian Basic Health Research in 2007, unfortunately I only have the one table from the 2007 because we need to have the raw data, but I don't have the raw data. This shows that TB, the proportion of TB is almost the same with proportion of stroke. So stroke is already almost similar with the TB. And then the next non-communicable diseases that high rank is hypertension and followed by diabetic. So if you see here, so it means that we already face lifestyle related diseases. The 10 risk behavior that related to some diseases that actually can be prevented is underweight, unsafe sex, high blood pressure, smoking, alcohol, unsafe water, poor hygiene and sanitation, high cholesterol, smoke in the closed area from tobacco or stove, iron deficiency, low and high BMI or body mass index. So if you see the table of the high rank of the cause of death in Indonesia, you see that the ischemic and then the hypertension and then diabetic is related to 10 risk behavior here. Some of the 10 risk behavior, for example, high blood pressure is related to the hypertension and then related to the diabetic, and then smoking and also high cholesterol is also related to 3 high rank diseases that I already mentioned previously. But according to the WHO, because the risk behavior is many, so they try to make easier to the people to be understood, so they simplify the unhealthy behavior into 3 things that they already campaigned several years ago. So the unhealthy behavior is less fiber diet, smoking or tobacco use, and then the less physical activity. WHO actually also campaign about alcohol and the use of anti-hypertension drug, but in some countries that mostly Islam, the alcohol use proportion is very low, and as well as the use of anti-hypertension. So finally, they campaign 3 things: less fiber diet, or we have to have the high fiber diet, we have to avoid smoking and doing exercise regularly. But unfortunately, according to the National Basic Health Research in 2003, the 3 healthy behavior is very low among the Indonesian population. So most of Indonesian eat insufficient high fiber diet. So only 6.5% of Indonesian people that eat high fiber diet properly. What they call properly is 5 times fruit and vegetables, or 3 portion of vegetables and 2 portion of fruit every day. But as you see in the table, Indonesian population or Indonesian is only 6.5 that eat properly on fruit and vegetables. And smoking. Smoking is still high prevalence in Indonesia. Among men, so 2 out of 3 of men in Indonesia above 15 years old are smoker. So the pattern is here from 1995 to 2013. The smoking prevalence among male in Indonesia never getting decrease. It's always increase or stable. So it's around 60% or 64, 67% of male in Indonesia are smoker. And the portion or the proportion or the prevalence of people, Indonesian people, that doing a physical activity, or we call doing exercise, is already 74.9. So but a quarter of the population is still less physical activity. In Yogyakarta, the pattern is not different with the national pattern. So but it's better for the eating high fiber diet, because 15 of the Yogyakarta population already eat high fiber diet. So this is one slide of the healthy behavior. So healthy behavior is not only not smoking, not only eating properly, but also dental checkup and then regular checkup if you already reach 40 years old and enough sleep. So how is behavior performed? So according this theory, if you do prevention for avoid the disease, you will perceive a benefit of doing that, but you also face a barrier to do that. For example, I will give example for myself, because I know that my parents has both of my parents have diabetic, so I know that I'm vulnerable to get diabetic, and I know that the diabetic is can be or can get severe. The condition can be severe. So, and I'm lucky because I teach in medical faculty, so a lot of my friends also warn me, and I have a lot of information by books, by participating in the seminar, so I know that I can prevent diabetic. 2, doing exercise regularly, and then 2, control my diet. So I know that if I'm doing the prevention, I can have a benefit, but I know that I'm busy. So maybe I don't have time to do exercise. But the last factor of this health belief model is self-efficacy. Self-efficacy is what they call confidence. I'm confident that I can do exercise regularly. So because I know that I'm vulnerable, but I know I can do it even though I'm busy, so I do exercise regularly. And indeed, I also do what I call high fiber diet. So health belief model have some explanation though. In order to change a behavior, a person must believe that he or she is susceptible to illness, and the occurrence of condition will have a serious impact of life. And following a particular set of health recommendation will be beneficial. But it's also the person will face the barriers to following to recommendation can be overcome. And recommendation will have psychological benefit. The other theory is what we call theory of reason action and theory of planned behavior. It is developed by Fishburne and Azen. And this theory said that the behavior, or what we call preventing behavior or healthy behavior, is influenced by behavioral intention, or in Indonesia we call niat. Yeah, if you don't have niat to do exercise regularly, you cannot do exercise. And then, but the behavioral intention is also influenced by attitude toward behavior, subjective norm, and as well as perceived behavioral control. But based on the two theories, so actually only 3 things that important for forming behavior. So if you want to have a healthy behavior, so you should have 3 things. These are strong positive intention. So if you want to do exercise regularly, you have to have a strong positive intention or niat yang kuat. And then the second is necessarily skills need. So maybe you can choose the exercise that you like very much, so you have skill to do it. If you like futsal, just do it futsal. And then, do it futsal is also the third factors is the lack of external constraints. So choose the exercise that available in your area. For example, if you know that your boarding house is near the futsal area, so just choose it, because if you like, and then there's already a near to your boarding house, so you have access and easily. So this can make you perform your healthy behavior. Now we will talk about prevention. So prevention is some of the we call the prevention divided into 3 things in the disease oriented. So primary disease prevention, and then secondary disease prevention, and tertiary disease prevention. Health promotion, but health promotion will be explained by another session. So health promotion is also has primary health promotion, secondary health promotion, and tertiary health promotion. Primary disease prevention is similar with the primary health promotion. I will explain in the next slide that the 3 types of this prevention: primary, and then secondary, and tertiary. The primary prevention is include activities to prevent disease or ill health prior to its occurrence. For example, immunization. If you do immunization, that can prevent communicable diseases, so you do the primary prevention. Secondary prevention, this action is taken to enable early detection of health problem and to stop or modify the severity of extent the illness and diseases. Activities in secondary prevention are screening, diagnose, and cure. And then tertiary prevention is actually to limit the disability of rehabilitation. So in the secondary prevention, maybe for me, because my age is almost 50, so I will do the pap smear because I'm in the age of the risk of getting the cancer. And then the tertiary prevention, for example, is if now I'm already diabetic, but I still doing exercise to prevent the diabetic getting worse. In order to change the behavior, there are some approaches that I will explain here is beyond the health promotion, because health promotion is, there is another lecture about health promotion. So beyond health promotion, we can change behavior through information, and then social marketing, incentive, restriction, and indoctrination. Information, I think you already exposed to some of the information about health. For example, on the television, sometimes you can see somebody said about the how to clean your hand, yeah, or wash your hand, and then you will see about the dengue, yeah, 3M. So this is information. Social marketing actually is adopting the marketing in the business to market or to campaign health messages. Incentive, for example, is like what already done by the Ministry of Health, is they have the coordination between midwife and traditional birth attendant collaboration. So if the traditional birth attendant would like to have collaboration with the midwife, they give incentive, and then vice versa. And then restriction, in Japan, the insurance will really strictly to non-smoker. So smoker will only have a very limited benefit. So this make the smoker think about getting insurance. So if they can stop smoking, they will have the similar benefit with other people. And then indoctrination is actually forcing people to do something. And then the last is policy. So this is the example of information. And then for change the behavior, there are some steps that according to Prokaska and Di Clemente, the step of change behavior start with the pre-contemplation, and then contemplation, preparation, action, and maintenance. So you can give some intervention based on the states. So pre-contemplation is never thinking about change behavior, and then contemplation is they already think but they haven't done it, and then preparation is start to change, and then action is really already changed, and maintenance is keeping the changing of behavior. So there are some intervention approach according to the states. This is the change behavior, but through the policy. This is what we call Framework Convention on Tobacco Control, that we hope that if country apply this one, but unfortunately Indonesia is the only country in the Asia Pacific that not sign this framework. So we not apply some of the intervention here. Yeah, so but even we haven't signed the ratification, or we haven't signed or ratified the Framework Convention on Tobacco Control, there are 4 best practices in tobacco control that fortunately our country or Indonesia has already done it. So increasing tax, and then banning all forms of direct and indirect tobacco advertising, promotion, and sponsorship. This is the only one intervention that Indonesia hasn't applied it. But we already apply smoke-free workplace or public places, and we also in our packet of cigarette we also already put the health warning. And I will give you a very short case of race behavior that here I will I choose a case of tobacco. So the toll of tobacco in 2030, in every year, is already 6 million people die from tobacco-related diseases, and more than 50% of these deaths occur in developing countries, including Indonesia, Malaysia. So, smoking kills more people worldwide than all the following combined: malaria, maternal mortality, major childhood diseases, and tuberculosis. And this can be the projection for the next 25 years. In 2013, there will be 10 million deaths per year, and 70% in developing countries. And unfortunately, the majority of these deaths will occur in China, India, and Indonesia. When we talk about the morbidity from tobacco use, people with smoking-related illnesses are sick for many years. They suffer, and their families suffer along with them. And this is the important thing, is economic burden for both family and the state. Tobacco is a significant risk factor for many chronic diseases. This is cigarette consumption in Indonesia is already increased 500% in 35 years. And tobacco is a risky behavior because tobacco smoke contains more than 7,000 chemical substances, and 60 substances have been identified as carcinogenic. So it causes cancer. So every cigarette is harmful. There is no cigarette and no safe number of cigarettes can be consumed, and cutting down or switching to low tar cigarette does not reduce the health risk of tobacco smoke. Many Indonesians and even Indonesian doctors misperceive that a person one can smoke up to 10 cigarettes without causing harm to their health. And secondhand smoke is also harmful because it can cause coronary health diseases, lung cancer, otitis media, asthma, sudden death syndrome. So there is no safe level of secondhand smoke. The impact of tobacco in economic is the household of smokers lose income due to lost wages when they ill because they cannot work, and direct and indirect cost of medical care. In low-income family in Indonesia, when the father is a smoker, more money may be spent on cigarettes than on the children education, even to buy the egg and then the meat. Money is spent on tobacco instead of food, causing child malnutrition. And then, how about kretek versus white cigarette? 90% of all Indonesian smokers smoke kretek and 10% smoke white cigarette. Kretek are inhaled more deeply because of the anesthetic effect of clove, because this also clove combining into tobacco, so they are even worse for health than white cigarettes. On average, kreteks contain more nicotine, more tar, and more carbon monoxide than white cigarettes. Poor households in Indonesia spend more money on tobacco than anything else except for rice. In Indonesia, poor families spend bigger percentage of their household income on tobacco, and average household tobacco expenditure in Indonesia is 10.4% of all expenditure, or the second highest after expenditure on the grains. So, as a candidate of doctor, you have an important role in controlling the tobacco. Doctor and cessation efforts, according to the article or based on the empirical data, doctors are key to any cessation effort, as doctors are opinion leaders and role models for healthy behavior. Doctors also have played a critical role in reducing the tobacco epidemic in many countries. Cessation intervention from multiple healthcare professionals are very effective. And the role of physician in tobacco control is also that if you asking about smoking and offering brief advice, so it can increase the chance of quitting by 30%. But yeah, unfortunately, not all physicians doing or asking the patient regularly. So physicians should routinely ask all patients about smoking status and advise patient to quit. Here is the slide of knowledge and practice of tobacco cessation among Indonesian physicians. So only 6.4 patient report of receiving advice to quit. The predictor of doctor in Indonesia to give cessation advice is a study of Indonesian physicians found that doctors who routinely ask patients about their smoking cessation status or smoking status were almost 3 times more likely to also advise patients to quit smoking. Physicians who felt sufficiently trained in cessation counseling were 2.5 times more likely to advise patients to quit smoking. And physicians who were former smokers were 2.5 times more likely to advise patients to quit smoking. And this, in the last of this session, I will give you that if you want to help your patient to quit smoking, there is a 5A strategy. A, the first A is ask, the second A is advise, and then assess, and then assist, and then arrange. Ask is asking their smoking behavior, and then you should give advice. Only 1 minute advice is very important to your patient. And then assess their willingness to quit, and then if they will or they want to quit, assist them to quit smoking. And then when they come again, you should arrange, and then you should ask them how is the effort of their quitting. So thank you. This is about the session. Thank you for your attention and hope to see you again. Salam.